Hello to everyone. Welcome to today's webinar. My name is Leah, and I'm the Director of Knowledge Exchange at Women's Shelters Canada. I'm going to host today's webinar, and I'm really excited to be here today to host this conversation. I think it's going to be a really interesting discussion, and I'm glad you could all join us. I want to start by acknowledging that I'm joining you today from the traditional unceded territories of the Algonquin Anishinaabe people. I also want to acknowledge my responsibility as a settler to continue to learn about the historical and the present impacts of settler colonialism and to support and the work of reconciliation and decolonization. I know there are many folks joining us from across the country today, so please feel free to say hi in the chat. Let us know who you are, where you're joining us from. We'd love to know who's in the room. Before we get into it, I'm just going to go through a few quick reminders. So as I mentioned at the beginning, we do have interpretation today. So if you go down to the bottom of your screen, you'll see a globe called interpretation. Click on that and choose either English or French, depending on the language you want to hear. If you do have any issues with the interpretation as we go through, just let us know in the chat, and myself or my colleague Nika will help you out. You've probably noticed that you can't turn your mic on, you don't have video. There are more than 50 folks here today, probably a few more joining. So we're going to keep the airwaves clear. Only the panelists are going to speak and have their video. But that doesn't mean we don't want your participation. We do. And so the ways you can participate, you can put comments, you can introduce yourself. If you have technical questions, anything like that, put those into the chat at the bottom of your screen. If you have a question for one of our presenters, please put that into the Q&A box that is beside the chat box. That just helps keep all the questions organized, makes it easy for me to make sure we get to everything when we get to the Q&A. Please feel free to put your questions in as we go through. We're going to save them till the end, but it's always good to have them come up as we go through so we can really get to as many as possible at the end. We are going to record today's webinar, and we'll share a recording afterwards. For those who registered, it'll also be on our website. And yeah, I think those are my housekeeping. So I'll jump in. As many of you know, this is the second webinar in a three-part series focused on harm reduction and lowering barriers to service. This webinar series has grown out of a community of practice on the same topic that took place between August of 2022 and June of 2024. In that community of practice, 25 shelters and transition houses from across the country came together to share their concerns, their practices, their lessons learned, their actions around harm reduction and lowering barriers to service. And this webinar series is a way for some of the folks in that community of practice to share some of what they've done, share their lessons, their practices with other shelters across the country. So that's what we're here to do today. So today we're going to be focusing on preventing, preparing for, and responding to overdoses and other critical incidents. We're going to hear from Amy of Gillian's Place in Ontario, who's going to share their experience of having a resident pass away in shelter and how they responded. We will then hear from Mirna and Kim of the YWCA Saskatoon in Saskatchewan, who are going to talk about the critical incident response protocol and the wellness strategy that they've developed. And then finally, we will hear from Alia of the Victoria Women's Transition House in BC, who's going to talk about the lifeguard devices that they have installed at their shelter. Before getting into that, though, we want to know a little bit more about who's in the room with us. So I am putting a poll up there, and we would love to hear from you. So we're interested to know what your role is. Are you an executive director, a supervisor? Are you really, frontline service provision or something else? And in that case, feel free to let us know in the chat what that other is. We're also curious how familiar you are with the harm reduction approach. Is that really familiar to you, somewhat, or not at all? So I'm going to give you a little bit more time to answer. All right, it looks like many of us have responded, so I'm going to close the poll and share those results. So we've got a good mix of people here, lots of frontline service folks, also supervisors, EDs, and a couple of other. Most folks, well, actually pretty evenly split between people who are somewhat familiar and very familiar with harm reduction, which is great. I'll stop that. Awesome. Thanks for that, everyone. And thanks to everyone introducing themselves in the chat. It's great to see you all here. Without further ado, I'm going to pass it over to Amy.
Hello, folks. So my name is Amy. I'm the manager of counseling services at Gillian's Place, and my presentation is going to be on an overdose that we had here on site and how we handled that. So let me just screen share here. Here we go. So on the day of our client's overdose, we fortunately had 3 staff on, so 2 counselors and a manager on site. So 2 of our first frontline staff were able to respond to the emergency, provide naloxone, while the other member of the staff provided childcare to the client's son, who was also present. So once we were able to call paramedics and police, so everyone arrived and took over the life-saving attempts for our client. The counselors were held back and were kept in the room during all of that time to kind of be kept separately so that they could be interviewed by the police while everything was still fresh. Um, so that was a challenge because then that left one staff really to man the rest of the building. Whoop, I just lost power in this room. Okay, didn't know it did that. Um, so the police secured the scene and we were interviewed. Then the emergency contact, which was the client's mom, was called and came to collect the child so that we were able to deal with everything else. Uh, we had, of course, to do our internal documentation. So the ministry report, our internal reporting, and all those pieces. So that was a bit of a challenge. We wanted to make sure we got all of those pieces done while it was still fresh. Unfortunately, folks, of course, had to fill that out while they were triggered. So that was a bit of a challenge. So we also did a debrief for those of us who were on site that day dealing with the situation. And we called in other staff to replace the counselors that were on site to take over all the needs of the building and our crisis calls and whatnot so they could really focus on the debrief, getting those reports in, and then everyone who was dealing with the situation was sent home. So that was helpful. So we put a post out to all staff to make them aware of the incident. However, we did call the folks who were coming in to relieve that day and the next morning before, so that they would have notice before they were walking into this very traumatic event that happened to our staff at the time. So we did hold a house meeting so that we could notify all of our clients. Of course, they saw the firemen and the paramedics and everything that was going on in the building. So we just did a higher level. We had a frank conversation about there being an emergency with someone's health, but we didn't go into detail about what it was. So they knew that there was something going on with someone's health, but not specifically. And then, of course, because the child was present and mom overdosed, we did have to notify Family and Children's Services of Niagara that that had happened. So the 2 weeks following, we really wanted to make sure that our staff were as supported as possible. So we brought in our outreach team. We kind of shut down the outreach department temporarily so that the outreach staff could come in and provide all the supports to the shelter clients. So they were able to do the crisis calls and all of that. So the counselors who were dealing with that client, on a regular basis as she was part of our residential shelter, so that they could lean on each other and have that time to themselves, have the time to support the shelter clients because they know them better, where the rest of the services were still being manned by frontline staff. So that was very helpful. So the staff directly involved were given approximately 3 shifts off without the loss of pay, just to have time to, grieve and deal with everything they needed to deal with. We decided to shut down no new admits for the first week so that we didn't have to add to that chaos. We're not bringing a new client into a shelter that's currently gone through a traumatic event, and we weren't taking on more work when we were really trying to turn internally for our staff and our clients during that time. So with staff that were directly involved had a private debrief offsite. We thought that doing it somewhere more neutral instead of making folks see each other for the first time back on site, we thought that might be healthier to just do it so we could have whatever emotions were going to happen seeing each other for the first time not being where it also happened. So staff seemed to find that very helpful. The staff that were directly involved had their shifts staffed longer so that if something came up and they were triggered by something right after. So I think we did that for approximately 2 weeks for those folks so that they could have extra support. If they needed to walk away and have some time, they were able to do that. The staff was, of course, reminded that we have the EAP and some community referrals were completed. So the EAP only has it's very specific counseling and supports that they could offer. And we have an attached trauma center in St. Catharines. So we were able to help some staff with that if they needed a little bit extra support dealing with their trauma. So that was very helpful. We were able to help them financially do that. So two debrief sessions were held by Women and Children Shelters of Barrie. So that was very lovely. So they came to us, they presented virtually. So they had had someone pass on site, not from an overdose, but they had been through the death in the shelter and how that hits all levels at in a different way. So that was very helpful. So thank you to them if anyone here is from the Berry shelter. Um, so we closed off the corridor to our bedroom. So basically our setup is we have the long hall and then we have little corridors and 3 rooms off of each corridor. So we just closed off that corridor so that no one had to walk by it during house check. No one had to enter the room to go in and see it. So we were able to really leave that room as it was. So that was great. We brought the family in to see the room. They had requested to do that. So we tidied it up a little bit just because it was a typical shelter bedroom. So we tidied it up a little bit, but was able to leave all of her belongings in. So they were really able to come in, see where she had been staying before she passed away, and what that time with us looked like. And then we had an Indigenous ceremony. So this client was Indigenous. So we invited folks in for that ceremony, and the family and staff, we closed off the entire main hall of the shelter and had this big ceremony with drumming and smudging, and they smudged the room, and it was just this beautiful closing ceremony that we were able to, offer tribute to this client who we had all worked with. So we did, of course, learn some lessons out of having to deal with this. So I'm ashamed to say, but we were very focused on how it affected the team and mindful of how it affected the clients in a different way. But afterwards, the clients expressed that they really wish they had have been allowed to join the ceremony, allowed to join the tribute. We closed it off thinking it would be more private and confidential, but they really expressed, that we knew this person as a client, but they were friends with her. And unfortunately, that was a piece that we missed, trying to maintain her confidentiality. So calling all staff directly to make them aware instead of doing the post. There were some folks who didn't see the post until after they were on site for the first time since it happened. So that hit some folks hard. And then they ended up having to leave the shelter. So making sure, you're not just calling the folks who are coming in, but really reaching out and making sure everyone knows. And then how much it affected not just the staff that dealt with the emergent situation, but really everyone connected to our agency. I like to say, and I'm sure you folks know this too, we all work in this field for a reason and we all have different life experiences. So everyone on all levels of the building were affected in a different way from this event and had their own trauma come up, perhaps from something that happened to them in the past or different things like that. Um, so another piece, even if you think you have control of the situation, you're able to manage it, everything's under control, really bring in help anyways. So that was something I learned. um, yes, you're able to deal with it and you're able to deal with it great, but that doesn't mean you should have to, and it's not going to hit you later. So even if you're able to handle it, you feel like you're okay, bring in the extra supports anyway. The same with taking time off. The folks who were able to take the time off and get the supports needed immediately were able to heal and do much better moving forward for those rather who tried to come back to work, thought they were okay, and then put off those services and then turned out not to be okay. So, really, just doing a health check and making sure you check in with yourself and really know that you're taking care of your own needs first. Another thing that was interesting was how overwhelming the support was for those involved. So everyone kind of rushed in to offer support, but that really was a lot for the people who were directly involved. So just being aware that different people handle support differently. So some folks might push away from it where others turn into it, and that's just totally natural, and just something to take away. So we have moved forward, always planning for this to happen, creating and running drills for an overdose just so it is able to build resilience. You know it's going to happen and you're ready for it to happen. Everything becomes second nature for the medical side of it. When needed, you're able to just jump in when fight or flight takes over and just go on kind of automatic response. So, additional measures we put in place since then. So, we created a harm reduction working group with staff across all departments, just so that everyone was well aware of our policies, could express any concerns, anything that the management team might not have taken into account, which ended up being great for us. We added a full-time mental health and addiction counselor to our staff so that our gender-based violence counselors could focus on that piece of our clients' health. And we had a specialist able to help with the mental health and addictions piece of our clients' lives because, of course, they co-occur so much. We have since added double staffing tonight, so we are now minimum double staffed 24/7. So that has been great, especially with the size of our shelter. It's been quite helpful. We gathered crisis and support resources. So it's just a little quick resource guide that we can hand out, and it has all the contacts for all of our community partners who are able to offer trauma counseling supports. And different pieces like that. So we've just got it on the go, nice and accessible if it's ever needed. We created a management training on crisis response as well as community um, presenting that information to the community. So, how to make the community aware of a crisis that happened and how to communicate that message to others. We created a crisis response team. So it involves managers and frontline staff. So we created a code word or phrase. So instead of having to call someone and run through everything that's going on in the immediate crisis, we can just type out, one word, one saying to all the other managers, and everyone on this crisis response team, and everyone will flock to the building. And then we've created the to-do list already and assigned members to each task. So as soon as you get that word, you show up on site and are able to jump into your tasks immediately. So that's a big help. So it's not all on one person or, scrambling at the last minute to try and step in to those roles. We've already got that planned out. And then we did an in memorial on the client's 1 year anniversary where we planted a tree. They had written a poem while they were staying with us, so we blew up that poem and framed it, and it's in the hall. And the biggest takeaway from me, we all go into this harm reduction world being very afraid of an overdose and what it will do to the staff. I personally was worried that it might turn staff away from harm reduction model. And I just wanted to say I found the complete opposite. It really turned the staff into harm reduction, why it's so important, looking at the fact that we are able to help these clients. Yes, unfortunately, she did end up passing away, but she passed away while she was safe. She was fed, her child was cared for. So it was really great to be able to service her in her last little bit of time with us. That's it. Just stop sharing here.
So thank you so much, Amy, for
No problem.
sharing that and walking us through that experience. It's I'm sure really helpful for folks to hear that. So I'm going to remind folks to put questions in the Q&A. We will get to them at the end. I do see some coming in. And for now, I'm going to pass it over to Kim and Mirna.
Hi, everyone. My name is Mirna, and I am the manager here at the YWCA Saskatoon Crisis Shelter and Residence. And let me just pull up my presentation here first before I go any further. Okay. Okay, so as I said, I'm the manager here. So what I'm going to go through, what myself and my colleague Kim will go through today with you is our crisis response protocol. And Kim will go through from the crisis response protocol. We also have established a wellness strategy for our staff. And so she'll go through that and I'll do the first part. So similar to Amy, after we encounter our first death of a client in the shelter, we recognize that we didn't have a procedure for staff or management to follow. So, and we learned as we went through the process that there's a lot to consider and is imperative to handle things delicately, but rather quickly. So it's easy to miss something. Oh, sorry, let me share this here. Let me share this slide with you. So it's easy to miss, really important things. And as with any sensitive matter, it is best practice to have a checklist and clear protocols as far as whose role is what, and in this in a situation like that. And so that's what we have put together. And we started putting a narrative and checklist together to try to provide some assistance to management staff. It was when we were involved in the community of practice that we learned about Amy's protocol, and so her and us have been working closely together, and she has shared that great resource with us, as well as we did draw upon the crisis the Crisis Trauma Resource Institute as well. So we were able to use those two tools to come up with our protocol. So first and foremost, we needed to identify what is a critical incident. As you guys know, working in this in the shelter setting, we do see incidents all the time. There are some incidents that we're seeing sort of on a regular basis, and so this protocol is more geared towards, the critical incidents. And how we identify that was based on this definition that came out of the Crisis Trauma Resource Institute, and it identifies it as critical incidents are extreme events that are out of the norm from our daily work. Because it is outside of our normal work, it challenges us to understand and cope what has happened. A critical incident typically causes distress, fear, and/or grief, with often significant consequences to individuals involved. So examples of this can include a death, physical or sexual assault, major motor vehicle accident, intervening in an active suicide or overdose, shootings, homicide, fire, flood, or natural disasters. So what how we have laid out our protocol is split into two different sections. The first section is it's around initial responses for actions that must be carried out as soon as possible following the incident. So things that you would do upon discovering either a death or an overdose, or somebody who is not unconscious. So assessing the emergency, making your assessment an emergency response. Securing the scene. So if, securing the scene, leaving it, so it's really specific under each section what you do. Gathering initial information, reporting what you would do for internal and external notifications, how you communicate this to clients, and also looking at your emergency schedule response. So similar to what Amy shared earlier is, looking at who needs, what staff need to be relieved, who do we need to call, what other communities resources you can draw upon to see if they can assist. And these are also things that we often don't think about, but are very important as well. So insurance actions and cleanup. So again, often we feel like maybe these things we can do ourselves, but it's important to identify it if you do need to have an external company come and do the cleanup, as we learned actually with the death we had, because it was an overdose. Sometimes, if it is fentanyl, for example, it can be lethal, and it can be very dangerous, and for to expose our own internal staffing to be in there and clean up. So we needed to look at it outside external people who do this and who have the expertise and the right equipment and all that to be safe. And then section 2 focuses on secondary responses for tasks to be completed, of course, days, weeks, or months after. So if you contact with family of the deceased, ongoing scheduling, figuring out, again, like if the staff that were directly impacted, directly involved, if they need to continue to have time off, as well as Amy outlined there, looking at if additional staffing needs to be put in place for some time to help staff cope with that. And then also supports available to staff, post-incident debriefing, support available to clients. So those are all the things, those are the two sections that we have. And so for us, as far as supports that we have in place for our staff, is the employee assistance program. This is individual counseling, of course. If they do, we're able to provide about 3 sessions, but they also have extended health benefits as well that they can also do further if they need it. Individual debriefing, group debriefing. We also have in our community, we have a critical event response team that actually is comprised of different nonprofit organizations. So we were able to, each organization has 1 or 2 staff on this team, and we actually received a 2-day training on critical incident debriefing, and we're able to draw upon this resource and call them out if when we need somebody to do this, whether as a group or individually as well. The other thing that this team does is also they can also do a hot wash. So what that is basically, this coming in as soon as early into right after the event has happened within a few hours, and is used as an informal check-in to see how the affected staff or those other individuals are doing. It is more of an informal discussion and identifying, those immediate needs, what kind of supports they are needing, and for at least the next, few hours. And then from there, we go and um, we go and offer the more formal critical incident debriefing, where it can take place between 24 to 48 hours, or even longer. It depends on what the need is, where it's again is more formal. And we talk, the discussion around discussion that happens is around reactions, coping, and how to access other supports. And also we follow up as well with the management team from that organization to put recommendations forward depending on what came out of the debriefing. So they also, of course, staff have we do have wellness time that our staff can take, and so that's also available. And we also have in this protocol, we have also put in some extra, information there, handouts for common reactions after, and also there's a test, sort of that, not a test, but like a questionnaire checklist for staff to do and identify where they're at, and if they're needing more support as well. And so we also acknowledge, of course, in this protocol that that there are incidents aside from the critical ones that staff are managing on a regular basis that have potential to cause distress. And I mean, these are suicide ideations, non-life-threatening medical emergencies, threat of violence, threats and aggression accompanied by behaviors of throwing items and property damage, mental health and addiction behaviors that can be unpredictable and accompanied by aggression. So we do acknowledge that, because these are important, because when staff are dealing with these such incidents all the time, these can also impact a person's well-being, and burnout. It can lead to burnout. And so what we do for these for the sort of the daily or frequent incidents is our protocol is that we suggest consulting and debriefing with the on-site manager and our shift partner, and the importance of adapting good coping and self-care strategies. Okay, so that's my part, and I'll hand it over to Kim.
Great, thank you, Mirna. So as Mirna mentioned, my name is Kim Fisher. I'm the Director of Residential Programs at the YWCA Saskatoon. So following up, not long after we encountered our first death of a client in shelter, we did start to see difficult and unusual crisis situations, which we could see was definitely taking a toll on staff. We saw that there were heightened feelings of fear. There was the fear of the unknown. This led to an increase in staff absenteeism, turnover, and signs of burnout were evident. So as we're continuously working in an environment where crisis incidents are unpredictable and common, and we see the need to create what we called a wellness strategy. And we wanted to do this to equip our staff with the appropriate tools for our environment and for our organization to evolve with the changing needs of our community. We were successful in receiving funding that allowed us to work with a consultant in developing a wellness strategy. So as you can see, the goal of the project was to promote overall wellness for all staff by providing tools, education, and resources for staff to utilize. These tools will support staff to feel safe in their workplace. So the project involved, the first was an environmental scan with recommendations for the organization. The scan was done through a trauma-informed lens. Data was collected by staff surveys, one-on-one interviews with staff and management, and a physical walkthrough. We were focused on the physical and psychological staff and client safety, staff wellness, and our organizational practices that promote and focus on wellness. And then we were also focused on trauma-informed acknowledgement and awareness. Next slide, Mirna. We then did a policy review. Management reviewed policies using a harm reduction and trauma-informed approach. We collected staff feedback throughout this process on applying the policies and how practical they might be on the front lines. As Mirna mentioned, we developed a traumatic response protocol, and we committed to using this resource at onboarding and then to revisit it annually. We brought in some wellness resources for staff. So by that, we held 2 workshops for staff. One was a resiliency workshop. It was called Power Within, and it identified workplace wellness strategies and some team building. In our report after, there was 89% of participants reported increased awareness of self and others in the workplace. And most participants showed subjective change in knowledge from their pre-workshop survey to their post. Some commented on a change in their level of empowerment of having an impact on their workplace community through their own positive actions. The other workshop we did was Unbalanced. It was education on working with those living with mental health challenges, decreasing stigma, and provide some intervention skills. So as part of YWCA Saskatoon's commitment to employee wellness, we partnered with Service Hospitality to conduct an organizational safety assessment and audit. So this assessment differed from the last one, as it was a more focus on physical safety in the environment, and it involved our on-site occupational health and safety committee. And I'm not sure if people in the webinar are familiar with Service Hospitality, but they are a nonprofit safety association who works with employers in the hotel, restaurant, laundry, and community service industry. They provide evaluation, research, consulting, education, and training services related to health, safety, and well-being for employers and workers in these industries. They offer on-site evaluations, safety training, individualized consulting, and a variety of other safety resources and tools. We found our working relationship with them very, very good. They came in and provided some really good insight, and we actually are still utilizing them as a resource. The assessment process was divided into 3 components. So again, we did an online survey of employees. And the surveys were confidential, and they went directly to the consultants at Service Hospitality. We had a supervisor one, and then a manager survey, and then a frontline worker survey. The documentation review of policies to look at what and how information regarding safety, health and safety is being recorded and what policies are in place. So this one again was different from the last assessment because this one was done by an external resource, and it wasn't us going through that. And then they did an observational tour or walkthrough to observe the safety management system in action and to check for gaps in the system. So they walked through our building, talked with staff right there on site, and asked them some questions as well, and could see, witness their work. From there, Service Hospitality provided recommendations to management, and then they developed an action plan. So as part of that action plan, recommendations were made for management and the OH&S committee, Occupational Health and Safety Committee, to have some training. So they had Occupational Health and Safety Committee training, and then hazard controls and assessment. And then there was a specific management training involved, and that was for health and safety leadership training. Next slide. And so, with the growing needs of our clients and to support our staff in feeling equipped to handle situations and de escalate when necessary, we developed a core curriculum of training that we've worked into our annual budget to ensure our full and part time staff have the following professional development. So, as you'll see, professional assault response training, applied suicide intervention skills training, mental health first aid, naloxone training, trauma-informed care, and harm reduction. That's all. Thank you.
Thank you so much, Kim and Mirna. That's awesome. So helpful to have all of this detail. So once again, I'm just going to remind folks to put questions in the Q&A right now before you forget what you wanted to ask Kim and Mirna. And while you're doing that, I'm going to pass things over to Alia for your presentation.
Awesome. Thanks, Leah. As mentioned previously, I'm Alia. I'm from Victoria Women's Transition House. I act as their residential supervisor for both our transition house and our third stage housing program. I'm lucky to work and play on the unceded territory of the Songhees and Esquimalt Nations. And so I'm just going to set up my PowerPoint here. So just give me 1 second.
Alia, I'm also going to ask if you can either speak a little louder or maybe bring the mic up a bit. You're a bit quiet. Thanks.
For sure. Hopefully this is better. Yeah, so today I'm going to talk a little bit about the installation of overdose prevention devices and how that kind of came across for our agency. So just a little bit about our agencies of Victoria Women's Transition House Society. Our shelter specifically works with folks who are women identifying and gender diverse, as well as their children who are at imminent risk of intimate partner violence or IPV. Our shelter has 8 rooms and 18 beds within the shelter, and we're 24-hour staffed. However, sometimes we are single staffed. We do have overnight staff that work here, and it is a sleeping shift for our overnight staff. The house was purpose-built, so rooms are upstairs and downstairs with a large communal kitchen, and we're lucky to have quite a bit of office space as well in our building. The approach for our shelter in terms of harm reduction is that we take a kind of behavior-based approach with an emphasis on safety for both clients and staff when working with someone who's using substances. So in practice, that generally looks like if folks are going to be using, they're not allowed to use on site. And if they are going to be using and coming back to the shelter, that their behavior is safe for both themselves and others. And that's kind of our approach there. But more specifically, we were able to come across some ways that we can increase our harm reduction within our shelter as well. And so one of those things through this community of practice through Women's Shelters Canada is we found out about a grant that we could apply for through the BC Nonprofit Housing Association that was called Overdose Prevention Devices Funding Initiative. And so that process, what that looked like is we applied for the grant, which we were made aware through this community of practice. And we were able to get 2 quotes from 2 different suppliers. So the 2 suppliers that came forward to us were both Lifeguard and another supplier called Brave Buttons. We went forward with Lifeguard, and I'm going to get into a little bit more about what Lifeguard provides a bit later in this presentation. But essentially kind of how this process worked is we completed a device request. So we provide information about the structure of our building and how many devices we would need and what we'd be looking for from this program. This then gets sent directly to Lifeguard as the provider. And then as well to BC Nonprofit Housing Association as well, just as proof that we sent in this request. We then are able to receive the funding, and upper management was able to sign off on this funding. So once we placed our order for the devices through the supplier, it gets notified to BC Nonprofit Housing Association that we placed our order, and they're able to provide the funding for that. In the case that potentially we needed more devices and the funding wouldn't cover it, our agency would have been responsible for covering those devices. That being said, if the amount of funding that we were offered actually was more than the amount that we needed, that funding would be returned to BC Nonprofit and actually is able to be used for another agency so that they're able to get more devices and or be able to use that funding for their support as well. So what services do we get from Lifeguard and what does that kind of look like? So Lifeguard itself is a company based out of Vancouver, and actually they were created originally as an app on a phone. So some people might be familiar with the Lifeguard app and how that might be used when using substances. I'm also going to get into a bit more about how to use the devices as well. But essentially, Lifeguard as a corporation was started from a lived experience kind of centered approach. This person named Jamie, who was lovely and actually is like very involved in the process, which is kind of a cool experience as well. Has lived experience and worked in harm reduction for a very long time and actually created the device herself and with the help of others and a team. And so we've kind of learned a little bit more about Lifeguard and all that kind of stuff. But essentially what's included in our Lifeguard contract is we get included the installation of the devices, a central emergency control panel, and as well, the funding will cover the installation of the overdose devices and a 3-year service package, as well as staff training and resident engagement resources. So more specifically, what that looks like is, so in terms of like pre-deployment of the implementation, that includes site visits for scoping for networks, specifications of design, the delivery and testing of the hardware, testing of the software, setup of the devices, also testing of the function of the devices, testing the systems through the emergency desk. And then in terms of deployment, that includes packaging, on-site configuration, installation of the hardware, configuration of where the responding panel is going to be, on-site testing, training for staff, as well as training for residents. And then as well, it also includes monthly maintenance. So there's 24/7 technical support that's included in this package as well, and 24/7 server support. So at any point, if there's any malfunction in any of the hardware, there's always someone that either management or staff can talk to help with either the iPad, which is the main control panel, or if there's an issue with one of the actual devices. There's also a specific iOS, which is like for Apple devices, and then as well for Android devices, they have 2 separate teams that they're able to deploy if needed, which is kind of cool. And then as well, they also will help with secure data management, project management, any sort of like emergency repairs or replacements. And then as well, they also help with any sort of alerts that might be coming through if folks aren't aware of what that means. And they also provide marketing materials and data analysis as well if needed. So that's a little bit about what kind of services we get through Lifeguard. But what do these devices actually do? So kind of essentially, like I mentioned before, it works very similar to if folks are familiar with a Lifeguard app. So essentially, the client or the person who is using the substance would start a timer by pressing the start button. And they can extend this amount of time as needed while they're using. If the client does not press the stop button or the I'm okay button after the amount of time has elapsed, there's going to be an alert that's sent to an iPad that's downstairs in our office. And that will basically designate that we either need to confirm that we need to call emergency services or that we say it's a false alarm everyone's okay. So essentially, Lifeguard also kind of very interestingly has their own patent with 911 and an ongoing relationship with BC Ambulance. So through this relationship, they're actually also able to send us toxic drug reports based on overdoses responded to within our area. And we actually get alerts sent directly to our iPad, which is also really cool. The device itself has a temperature monitor and a smoke detector built into the device. So not only is it able to help with safety in regards to actual use, but it's also helpful in regards to safety around fire safety and all of that other stuff as well. So if folks are smoking in their room, it would detect that as well. Um, Sorry, I'm getting all jumbled in my notes here. Kind of moving back to how folks are able to use this device as well. It can also be used in medical emergencies. So if people are, for example, prone to seizures, people can also press that start button if they are feeling like they're having a seizure. And if the time has elapsed and they're still in that state, staff would be notified downstairs as well. So it can kind of be used as like a panic or help button also in terms of medical emergencies. The device never collects any sort of personal information about the client. The only thing that staff get notified about is what room is having the emergency and where it's coming from. So essentially, if staff respond to the emergency, they go and check out what's going up upstairs, and they bring their phone. The phone is going to also ring because it's connected to our shelter cell phone, and lifeguard's going to confirm that we would like emergency services to be called. If they call us and we don't respond back, they're going to send emergency services anyway. Um, do do do. Also as well for folks who may have like complex needs that are coming into our shelter, or if there might be like children who might be playing with this device, you can also turn off the 911 feature because you can call 911 directly from the device as well. So that also can be turned off if needed. And then as well, Lifeguard will check in once a month with us to make sure that all the devices are working, and as well that folks are able to use it. So when the device gets installed, also really cool, Lifeguard will provide any sort of like additional hardware that we might need to make sure that it's safe and put in the room and that it's easily accessible. They also provide all of the sort of like informational packages for clients as well. So any sort of like posters that go next to the device that basically describe how to use the device is all provided by Lifeguard. And those can get set up and also handed out to residents as needed. They also, we go through quite a long training process as management on how to train our staff and things to expect during the installation. So I'll kind of move forward with that. So training staff and residents. So Lifeguard provides extensive training to both management and then also supports with the training of staff upon the installation. So even before our installation, we meet with Lifeguard every 3 weeks and get a little bit more information about what our installation is going to look like. We provide information about our shelter, how many devices we might need. Also super kind of things that you don't really think about, but if some rooms may not have great service or you might not get the best Wi-Fi, Lifeguard will even provide like Wi-Fi extenders and or service boosters to put in the room to make sure every device has the exact same amount of signal so that every device is working the exact same. And so those kind of like 3-week ongoing installation meetings are a chance for us to speak directly with Lifeguard about what our shelter specifically is going to need, and specifically as well, like what training our staff are going to need as well. So in terms of staff training, they provide all of the resources that we would need to train our staff, so that we have physical, like paper copies of things. They provide PowerPoints, and then as well, they also provide tips and tricks on how to train staff as well, how to use the devices. And then along with that, they also provide information on how to train residents to use the devices as well. So also how to kind of, what's the word I'm looking for? make folks aware of like what the device is, how not to worry about the device being in their room. It doesn't mean that they have to use it, that it's not monitoring them all the time, all of that sort of stuff, that there's a smoke detector in it, where to go to look for more questions, all of that sort of stuff. And they provide anything from pamphlets, posters to infographics as well. They also offer to come in and train residents directly because our stay is only 30 days. That isn't necessarily super helpful for us, but I can see for some folks who might have long-term facilities, it might be helpful to have lifeguard come and actually do the training with the residents themselves. As well. So there are some kind of upsides and downsides. So some strengths and challenges. So some of the strengths during our installation process that we had. So lifeguard is very hands-on. They're in constant communication, always asking questions, and it felt like a very hands-on approach that they took. They also provided all the labor and materials and training for the installation as well. So there's not a lot of work that we had to do other than just kind of organizing dates and times for things to happen. Also, a really big strength is that it comes from someone with lived experience. So this is someone that would use the device themselves. And I think that that was such a huge strength throughout the process, hearing that experience. They also were able to provide tips for training staff and residents. And I found that that was very useful, some of the tips that they had. And then as well that the device is multi-purposeful. So not only is it used in specifically medical emergencies such as overdose, but it can be used in any sort of medical emergency as well throughout a stay. So I think that that's also something to note. Some challenges that kind of presented, there was concerns from staff that because we're getting these overdose prevention devices, our policies are all changing and we're moving to a completely different approach. So there was a lot of kind of reassurance that was being brought forward, and making sure that folks knew that we're not changing anything outwardly. We're just making sure that we have those prevention devices in place to make everything more safe. And if it were to come to us, becoming even a bit more low barrier, we have the infrastructure to make that work and make it be safe. But that, so there's a little bit of coaching involved with that. And then as well, there's also some concerns from residents, oh, does that mean that other people are, using in the house, specifically from families, which is understandable, but, mostly just like coaching around, what the device does and why it's there, and that it doesn't need to be used if it doesn't have to be. And then as well, this is maybe more of just a personal challenge, but there was lots of pre-installation meetings, which took up a lot of time. But I think that also, on the other hand, it was also very helpful. So some of the pre-installation process definitely could be a bit tedious, but I think that all of those questions and everything that were asked during that time were definitely very helpful. So overall, installation process, definitely very hands-on, and super thankful that we were able to receive the funding to have these. And I think that it adds an extra level of safety for staff and residents, and just overall. But yeah, thank you. I really appreciate your time.
Thank you so much, Alia. It's so interesting to have that deep dive into what these devices are and how they're used. All right, well, that brings us to the end of our presentations. So we're going to move into the question period. I do have some questions lined up here that have come in while folks have been presenting. We have lots of time, so I'm going to encourage everyone to keep adding questions into our list here as we start going through. So, just to start, there's been a couple folks who've asked about some of the resources that you guys have mentioned developing. So, for example, Amy, you mentioned a to-do list for incidents. Mirna, you were talking about a protocol that you've developed. So curiosity about whether some of those resources could be shared with folks. So maybe I'm just noting those. I'll follow up with presenters afterwards, and if there are things we can't share, we'll include that with the recording and the presentations afterwards. So with that noted, Amy, I'm just going to ask to start. So there was a question that came in about the debriefs, mentioning that staff who were directly involved received debriefing off-site. Was there any debriefing for other staff who were not directly involved? I know you answered that in writing, but I'm just going to ask you to answer out loud too for folks who aren't looking at the Q&A.
Certainly. So that was a misspeak. So the debriefing from the Berry shelter was available to all the staff organization wide. So they led 2 different dates and times to accommodate everyone from the organization. The one offsite was just for the folks that were immediately involved so that we could talk through our own parts and how we felt going in, how the day went, and so we could have that time together. But certainly the one from the Berry shelter was organization wide.
Awesome. Thank you, Amy. Another question that came from your presentation, I think you had mentioned doing drills afterwards. And so someone wondering if you could just talk a bit more about like what those drills are, what they look like, a bit more on that.
Yeah. So part of the protocol we put together is we have emergency bags in various locations of our building, and all of our outreach staff carry them also. So they contain an naloxone kit, first aid kits, and other immediate items that you may require. So we haven't actually done any yet with all the staffing challenges. But the idea is if someone is in an overdose in the backyard, having staff go out, grab the bag, crowd control, and being mindful of the time, um, how to do naloxone, running through how to do CPR, and all those pieces if required.
Awesome. Thank you. So the next question is for anyone who wants to answer. Someone curious whether clients are able to keep paraphernalia in their rooms. If yes, used or unused or both. So I'll let anyone who wants to speak to this jump in.
I can start us off. So we have safes in all of the client rooms as well as sharps containers. We don't look in the safes during house check as long as their items are locked up. We trust that that's in a safe place to do so. So yeah, whatever's in their safe, we don't go through the safe unless they discharge and leave those items behind. Or if there's someone expressing suicidal ideations, we might go through just to ensure there's no harms that could potentially come to them in those safes.
Ours is a very similar policy to Amy. We have safes in all the rooms, and folks are encouraged to keep important items in there, including whatever that may be. And then in terms of marijuana use, we ask that folks keep either their gummies or their pipe or their weed in the safe as well. And we have smell-proof bags that we provide folks to minimize the scent. If folks are using things like a bong or something like that, then we have a locker outside that they can store that in to minimize smell and things like that. But they have to use off-site, so they have to get their paraphernalia and use off-site.
So for us, so they're not able to use in the building or in their rooms. So they're not able to use paraphernalia in the rooms. However, they can keep, unused harm reduction supplies. That's something that they're able to do, and we are able to store medicinal marijuana in our more like a secure, where we store kind of our medication. Yeah.
Awesome. Thank you. So there's been a little bit of conversation in the chat about fentanyl strips, and I'm just going to sort of bring that up here out loud for folks not following the chat. So someone sharing that they recently purchased fentanyl test strips for women to use and fentanyl wipes for detecting the substances. Has anyone used those as part of your harm reduction tools? While not 100% effective, they can add an extra tool to the safety kit. And I'll just say as well, before opening it up to you folks, that Sophie, who facilitated the community of practice that we've been talking about today, put quite a bit of information in the chat as well there. So if folks are interested, you can read that, but basically agreeing that they can be useful, although not 100% full safe. and also some information about legal things and where to get them. So that's in the chat, but I'm going to open it up to any of our presenters if any of you have used the fentanyl strips, to just share a bit more about that. And if not, that's okay. I will note that one of the presenters in last week's webinar did talk about fentanyl strips, and sort of agreed with what's been said in the chat around they're a useful tool to have in the toolkit. They're not the only thing you want to rely on, but it's an option. And this is an excellent reminder that I will be sharing the recordings of the past webinars and this one once it's done. And so for the folks interested in the fentanyl strips, I recommend watching the recording from webinar 1. Another question around, so when shelter clients use substances off property, for example, in front of the building, how do you respond to or address neighbors complaining about people using in their neighborhood? And this I'll open up to anyone who wants to answer.
We haven't gotten that complaint, so I can't answer that.
Same with us.
So I can answer. We do. Our shelter is actually right. We're really not in a residential setting, but right next to us there is a seniors residence, and so we do get that. We also have a deck off of our building too, so sometimes we get noise complaints of women being out there, and yeah, we do. We are also a public building, so there's patrons that are coming into our building, and there's a childcare on site. So we deal with that quite regularly about people making complaints about smoking and use. We do find that the women that we're housing are quite respectful about their use, and they'll go across the street and do it there. But then there are times when they're doing it more in front of the building, and we have those conversations with residents and encourage them to use elsewhere, and out of sight. And I have had conversations with some of the tenants that live in the residence next to us, and just trying to do some awareness and education, and about like who we are and who we're serving. And I found that just even with our clients, building the relationships is really important, and I think even just the community relationships as well, doing some education and awareness. We do find that has helped. I wouldn't say I'm definitely successful 100%, but it's important to have those conversations and give the awareness when you can.
Amazing. Thank you so much. There currently aren't any other questions in the Q&A, but I'm going to leave that open and let folks put things in. We do have time left to answer questions, so feel free to pop those questions into the Q&A. While folks do that, I am going to remind everyone, as I've said, we do have another webinar coming up next week in this harm reduction series. So I've just put the link in the chat if you want to register for that one. Next week's webinar focuses on keeping children and parents safe in the context of substance use and harm reduction. So that's going to be a really interesting conversation as well. So I've put that in the chat for anyone who hasn't registered for that yet and wants to. That's on Tuesday. I'm going to wait a few more seconds in case there's other questions. The questions always come in right as I assume there's no more and start wrapping up. so I'll wait a minute longer. All right, so I will also, my colleague Nika is going to put in the chat the link to, oh, see, as soon as I start wrapping up, a question comes in. All right, so yeah, so another question about, sharing some of the response protocols and the to-do lists and some of the resources developed. So we will, the presenters and I will touch base afterwards, and anything available to share, we'll share with the recording and the slides. Yes, there we go. All right, so my colleague is going to put into the chat a link to a feedback survey, and that will also appear once you leave the webinar on your screen. We do welcome your feedback. It helps us know what to do better next time, what other topics you want to learn about, that kind of thing. So please do take a second to fill that out. It's pretty short and sweet. We do have a question that's come in, just adding to the resources folks are interested in terms of the staff surveys. So I'll add that to my list of things to check in about. Awesome. Great. So on that note, I will thank all of our presenters. So thank you to Kim, to Mirna, to Amy, to Alia. These were really informative presentations, so helpful to have this detail. I want to thank my colleague Nika for helping with the chat, our interpreters for a wonderful job making this available to everyone. I want to thank Sophie, who has been in the chat, and she did a lot of work getting these webinars set up, so I want to shout her out as well. And of course, everyone in the room with us. There's been almost 80 of you over the course of the webinar, which is wonderful. We're so happy to have you all here, and it wouldn't be what it is without you. So thank you so much to everyone who's participated, and we look forward to seeing many of you again next week. So thank you, everyone. Bye. Have a great rest of your day.